speaking on fascial plane blocks for thoracic surgery. These are my declarations. Now, what is a fascia? Fascia is a soft collagen containing loose and dense fibrous connective tissue which permeates the whole body. And in the body, you have got a superficial fascia, the deep fascia, and muscle and related fascia. It is this deep fascia or a multi-layered fascia which contains in which the nerve travels, and these deep fascia is the target for any interfacial plane blocks. Now, what are the facial plane blocks? The interfacial plane block is in which LA is injected into a tissue plane rather than directly around the nerves. And these blocks work by the passive spread of LA to the nerves traveling within that tissue plane or to the adjacent tissue compartment containing the nerves. And they only provide analgesia as a part of multimodal analgesia. So what is the mechanism of action of interfacial plane blocks? It is mainly due to the conduction blockade of the sensory efferent due to the LA action on the direct spread to the nerves running within that plane, or diffusion due to the concentration gradient into the surrounding muscle and fascia, where they act on the peripheral nociceptors. The ribs, the associated joint and connective tissue are important source of pain and are innervated by the multiple branches of intercostal nerve. So by the diffusion gradient, these peripheral nociceptors of the ribs and associated connective tissue are blocked. And also the perforating nerves branches and the accompanying vessel provide a potential channel for the spread of local anesthetics, and this is further enhanced by the tissue disruption in the trauma and surgery and the system absorption, which is one of the actions. So these are the four different mechanisms of action of interfacial plane blocks. Now, if you see a typical spinal nerve, this is a dorsal root ganglion, this is a ventral root ganglion, this is a sympathetic connection from the visceral, and then they divide into dorsal ramus and a ventral ramus. So if you block from here, this is where the interfacial plane blocks act. So they provide only the somatic analgesia because the sympathetic are not covered. So it gives analgesia for the skin, the muscle, the bone, the parietal pleura and peritoneum if you are doing abdominal interfacial plane blocks, and these provide only analgesia. But if you are blocking medial to it, you get a surgical block and you get also visceral analgesia. So which is where the epidural and paravertebral work, and erector spinae and quadratus lumborum block are might work. So it's a controversy, but it may work or it might not work. Now coming to the innervation of the chest wall. So you have got the sensory or cutaneous innervation from the supraclavicular nerves just below the clavicle by the so it is a part of the cervical plexus now, and you have got innervation from the anterior cutaneous branches of the intercostal nerve and the lateral cutaneous branches of the intercostal nerve from T2 to T7. Also, you get innervations of the ribs, the sternum, and the intercostal muscle innervation from these intercostal nerves, and you have got the motor innervations from the lateral pectoral nerve, the medial pectoral nerve, the long thoracic nerve, and thoracodorsal nerve, which are a part of a brachial plexus. So if you see the innervation of chest wall, it is from the cervical plexus, that is the supraclavicular nerve, from the brachial plexus, that is the lateral pectoral nerve, medial pectoral nerve, long thoracic nerve, and thoracodorsal nerve, and from the thoracic spinal nerves, that is the anterior and lateral cutaneous branches of the intercostal nerve. Now coming to the intercostal nerve. Intercostal nerves are the ventral ramus of the thoracic spinal nerve, which run between the innermost intercostal muscle and the inner intercostal muscle, and at the level of axilla they give the lateral cutaneous branch, which which divides into anterior and posterior branches, and this nerve again runs between the internal intercostal muscle and the transverse thoracic muscle, and they give rise to anterior cutaneous branches, which again give rise to medial and lateral branches. So if you divide the interfacial block of the chest wall, it is the enteromedial blocks, which blocks the anterior cutaneous branches of the intercostal nerve, and which is the pecto-intercostal fascial plane block and transverse thoracic plane block. Anterolateral blocks, which block the thoracodorsal nerve, the lateral cutaneous branches, the long thoracic nerve, the lateral pectoral nerve, and the medial pectoral nerve. And the blocks are the PEC1 block, the PEC2 plus PEC1 block, the Serratus plane block, and wrist subserratus. And last is the posterolateral block, which blocks at the level where the ventral and dorsal ramus come out, that is the retrolaminar nerve, the rectospinal block, the MTP block, and wrist rhomboid intercostal blocks. So these are the different interfacial blocks of the chest wall. Now coming to the pec block, it is divided into pec 1 and pec 2. Pec 1 where you deposit the drug between the pec major and minor muscle, and pec 2 where you deposit the drug between the pec minor and serratus muscle. And if you combine the two, it becomes a modified pec 2 block. So PEC 1 block, it blocks mainly the lateral pectoral nerve and the medial pectoral nerve. They give only myofacial anesthesia. There is no cutaneous anesthesia, but it reduces the proprioceptive pain from the stretching of the pectoral muscles during the surgery. PEC 2 block, it blocks the lateral cutaneous branch of the intercostal nerve from T2 to T6, and it provides cutaneous analgesia of the anterolateral chest wall and axilla. So this is the dermatome which is covered when you give a PEC 2 block. Now coming to the anatomy, this is the pec major muscle. If I remove the pec major muscle, you can see the pec minor muscle, and you can see the pectoral branch of the thoracoacromial artery, and just along with it, you can see the lateral and medial pectoral nerve. If I deposit the bring the needle at this level, and if I deposit the drug, it becomes a pec 1 block. Now, if this is a pec major minor muscle, this is a serratus anterior muscle. If I remove the pec minor muscle, this is the serratus anterior muscle, and you can see the lateral cutaneous branches of the intercostal nerves running on the serratus anterior muscle. If I put the needle between the pec minor and the serratus anterior muscle, it blocks the lateral cutaneous branches of the intercostal nerve from T2 to T6, and it becomes a pec 2 block. Now coming to the sonoanatomy, the patient is placed supine with the arm abducted. A high frequency linear probe is placed in a parasagittal orientation below the clavicle, medial to the coracoid process. And this is the sonoanatomy which I get. This is the pec major, this is the pec minor, and this is the axillary artery. Now I will tilt my probe medially to bring in line with the deltopectoral groove, and I start seeing the second rib and the pec major muscle, pec minor muscle, the axillary vessels. And the probe is slid inferiorly and laterally. As I slide it inferiorly and laterally, I start seeing the third rib and a slip of serratus anterior muscle below the pec minor muscle, the intercostal muscles, and the pleura. And again, if I slide inferiorly and laterally, I see the fourth rib sitting on the top of fourth rib with the serratus anterior muscle, the pec minor muscle, and the pec major muscle. And if I bring the needle between the pec major and minor muscle, it becomes a pec 1 block. If I bring the needle between pec minor and serratus anterior muscle, it becomes a pec 2 block at the level of third or fourth rib. Now, this is a pec 1 block. In-plane needling is done from cephalad to caudate. You can see the pulsating branch of the thoracoacromial artery, which is an important landmark. And as I inject the drug, I will unzip the plane between the pec major and minor muscle. Coming to the pec 2 block, at the level of third and fourth rib, 20 ml of 0.2% ropivacaine is injected between the pec minor and serratus anterior muscle, and as I start injecting, I will unzip the plane between the pec minor and the serratus anterior muscle. Now, what are the indications of pec 1 block? It is for ICD or pacemaker insertion, for breast expanders, for pec muscle surgery, and as a part of, along with the pec 2 block in modified radical mastectomy. In modified pec 2 block, indications are mastectomy with or without reconstruction, wide local excision of the breast for axillary clearance, and for the sentinel node biopsy. Now coming to the pec block tips, do pec 2 first, then do pec 1, 10 ml for pec 1, 20 ml for pec 2, pectoral branch of the thoracoacromial artery, pleura, third and fourth rib are important landmark. Keep the needle tip always in view. Aim needle to the third or fourth rib for safety during needling, and if you are giving a bilateral block, beware of last. Now coming to the serratus anterior plane block, it is divided into superficial and deep. If you deposit above the serratus anterior muscle, that is between the latissimus dorsi and serratus, it is the superficial SAP block. If you deposit below the serratus anterior muscle, between the serratus anterior muscle and the fifth or sixth rib or the intercostal muscle, it becomes a deep SAP block. Now, what are the nerves which are blocked in superficial SAP block? It is the lateral cutaneous branches of T2 to T9, the intercostal brachial nerve, the long thoracic nerve, and thoracodorsal nerve. But in deep SAP block, and this is the cutaneous analgesia, which is area of distribution, which is provided with a superficial with a SAP block. But in a deep SAP block, only the lateral cutaneous branches of T2 to T9 and intercostal brachial nerves are blocked. Now coming to the anatomy, this is a latissimus dorsi muscle. And as I remove the latissimus dorsi muscle, you can see below the latissimus dorsi, the serratus anterior muscle. This is the thoracodorsal artery. This is a long thoracic nerve, and you can see the branches of the lateral cutaneous branches of the intercostal nerve. If I deposit the drug between the latissimus dorsi and the serratus anterior muscle, it becomes a superficial sap block. If I remove the serratus anterior muscle, below the serratus anterior muscle, you can see the branches of, these are the ribs, these are the lateral cutaneous branches of the intercostal nerve. If I bring the needle between the serratus anterior muscle and the rib and I deposit the drug, it becomes a deep sap block. Now, this is the sonoanatomy. The patient is plain supine with the arm abducted. High frequency linear probe is used in a transverse orientation at the mid axillary line at the level of nipple. And this is the sonoanatomy which I will get. This is the latissimus dorsi muscle. This is the serratus anterior muscle. And this is the rib. This is the intercostal muscle and pleura. And you can see the pulsating thoracodorsal artery here in the sonoanatomy. If I bring the needle between the latissimus dorsi and serratus anterior muscle, it becomes a superficial sap block. If I deposit the drug between the serratus anterior muscle and the rib or the intercostal muscle, it becomes a deep sap block. So this is the way I do my superficial serratus anterior plane block. This is the latissimus dorsi. This is the serratus anterior muscle. This is a pulsating thoracodorsal artery. As I will inject, I will unzip the plane between the latissimus dorsi and the serratus anterior muscle. And this is the way I do my deep serratus plane block. This is a sonoanatomy pic. You can see the latissimus dorsi, the serratus anterior muscle. This is the rib, and this is the intercostal muscle here. And as I will start injecting, you will see the unzipping of the plane between the serratus anterior muscle and the rib. As I start injecting, you can see the unzipping of the serratus anterior muscle from the rib, and I will deposit around 20 to 30 ml of local anesthetic with or without adrenaline. So what are the indications? Mastectomies with axillary clearance with or without LD flap, thoracic surgery, rib fractures, cardiac surgery, VATS, and chronic pain. So what are the tips and tricks? Serratus anterior muscle can be performed in both supine and lateral position. 20 to 30 ml of local anesthetic is commonly given. Superficial sap block is preferred. Deep sap block is ideal for rib fractures. And what for the thoracodorsal artery? It is also it is a useful landmark, and also you have to avoid while you are doing your needling. Now coming to the parasternal block for the enteromedial branches, for the enteromedial aspect of the chest, there are two blocks which are discussed. These are the pectointercostal plane block and transverse thoracic plane block. The pectointercostal plane block is the interfacial plane block between the pec major and the intercostal muscle, and transverse thoracic plane block is the interfacial plane block between the intercostal muscle and transverse thoracic muscle. And they provide anterior block the anterior cutaneous branches of intercostal nerve from T2 to T6, providing cutaneous analgesia of the enteromedial chest wall. This is the area where cutaneous analgesia will occur if you are giving a parasternal block. So coming to the anatomy, this is a pec major muscle. As I remove the pec major muscle, you can see the intercostal muscle and you can see the anterior cutaneous branches. If I deposit the drug between the pec major muscle and the intercostal muscle, it becomes a pectointercostal facial plane block. And as I remove the intercostal muscle, you can see the slips of the transverse thoracic muscle here, along with the internal mammary muscle and the anterior cutaneous branches. So if I deposit the drug between the intercostal muscle and the transverse thoracic muscle, it becomes a transverse thoracic plane block. Now this is you can do the block either in a parasagittal orientation or in a transverse orientation. This is the sonoanatomy. If you are giving in a parasagittal orientation, we use a linear probe lateral to the sternum at the level of 4th or 5th rib, and in-plane needling is done from caudate to cephalad. And in sonoanatomy, you will see the rib, you will see the pec major muscle. Between the two ribs, you will be intercostal muscles, and below there will be a thin muscle that is the transverse thoracic muscle, and this is the pleura. If I deposit the drug between the pec major and the intercostal muscle, it becomes a pectointercostal facial plane block. If I deposit the drug between the intercostal muscles and the transverse thoracic muscle, it becomes a transverse thoracic plane block. And you can also do in a transverse orientation, a high frequency linear probe is placed in a transverse orientation between 4th and 5th rib. Between the 4th and 5th rib, and in-plane needling is done from lateral to medial. This is the sonoanatomy which you will get. In medially, you will have the sternum, the acoustic side of the sternum. You can see the pleura, a thin slip of the transverse thoracic muscle, above that an intercostal muscle and pec major muscle. If I deposit the drug between the pec major and intercostal muscle, it becomes a pectointercostal fascial plane block. And if I deposit the drug between the intercostal muscle and transverse thoracic muscle, it becomes a transverse thoracic plane block. Now, this is the way I do my pectointercostal fascial plane block. This is the pec major muscle, this is the intercostal muscle, and as I will inject, I will try to unzip the plane between I will try to unzip the plane between the pectointercostal muscle and the transverse thoracic muscle. And this is the way I will do my transverse thoracic plane block. I will bring my needle from lateral to medial and try to place my needle between the transverse thoracic muscle and the intercostal muscle, and I will try to unzip the plane between the intercostal muscle and the transverse thoracic muscle. As I will start injecting, the plane between the intercostal muscle and transverse thoracic muscle will unzip and it will open. 20 ml of 0.2% ropivacaine will be injected each side. What are the indications? Indications of sternotomy, sternal fracture, medial rib fracture, medial coverage for the breast surgery, and medial coverage for the placement of tunnel pacemaker or ICDs. So what are the clinical indications? If you see, this is a meta-analysis of comparison of PEC2 versus IV opioids. The patient who were given PEC2, they had a better pain score in first 24 hours after surgery. Coming to the another randomized trial of use of Serratus anterior plane block for analgesia after thoracic surgery, the patient who were given Serratus anterior plane block, they were more satisfied. And this is another paper where ultrasound guided Serratus anterior plane block was used for analgesia for thoracic surgery. Patient who received the Serratus anterior plane block, they had a better VAS score and the post-operative morphine consumption was less. And this is a paper comparing PEC2 block with a rectus spinae plane block. The patient who were given PEC2 block, they had better VAS score and less opioid consumption. This is one paper which compared the Serratus anterior plane block with the paravertebral block in VATS, and the NR VAS score was almost comparable between the Serratus anterior plane block and the paravertebral block. So the conclusion was there is no difference between the Serratus anterior plane block and paravertebral block. And this is one paper which compared the Serratus anterior plane block with thoracic epidural analgesia for thoracotomy plane. Patient who received epidural analgesia, they were slightly more hemodynamically unstable, but there was no difference in VAS score between the Serratus anterior plane block group and the thoracic epidural analgesia group. So the authors concluded that Serratus anterior plane block is safe and effective. And this is one paper on the anesthesia and surgical management of rib fractures, and a patient for rib fracture, for anterior and lateral rib fracture or bilateral rib fracture, and even in posterior rib fracture, they have given Serratus anterior plane block. And this is one paper which compared transverse thoracic plane block in cardiac surgery. Patient who received transverse thoracic plane block, they had a better numerical rating scale at 12 hours, and the time to extubation was less. Due to paucity of time, I will not be speaking on the posterolateral blocks. So where may the fascial plane blocks have a role? If you can't, if there is no epidural, if you can't place an epidural or a paravertebral catheter because the patient is has a coagulation deficit defect or a sepsis, or in a cardiac surgery, you don't want a hypotension in your patient, or as a rescue technique, if your epidural or a paravertebral has failed, and if there is an inability to perform an epidural or a paravertebral because of the patient positioning, due to the lack of a skill of the operator and or the lack of the post-op monitoring. So in these situations, the fascial plane block have a role. So what are the options you have for a block combination for the complete analgesia of the anterolateral and anteromedial hemithorax? So first, if you want to block the anterior cutaneous branches of the intercostal nerve, you can use any of the anteromedial blocks like the pectointercostal fascial plane block or transverse thoracic plane block. For the PEC1 block, you can use a lateral pectoral nerve and the medial pectoral nerve blockade, that is a PEC1 block. For the intercostal brachial, long thoracic nerve, thoracodorsal nerve, and the lateral cutaneous branch of the intercostal nerve, you can use either the Serratus plane block or a modified PEC2 block. And for the supraclavicular nerves, you can go for a supraclavicular nerve block. Or you can use any of the posterolateral block along with a PEC1 block to block the medial pectoral nerve and the lateral pectoral nerve, and the supraclavicular nerve block for the skin just below the clavicle. So to conclude, there are 6 truths of the fascial plane block. First, fascial plane block are a heterogeneous group of techniques. Facial plane block mechanism of action are still debatable. Facial plane blocks are unpredictable. Facial plane block may have a role in absence of epidural or paravertebral blocks. Facial plane block provide only analgesia as a part of multimodal analgesia, and facial plane block have increased the delivery of regional anesthesia practice because many of the performers, they are not very comfortable giving the thoracic epidural or paravertebral, and in these patients, if you don't go for a good acute pain management, there are chances that these patients will go into a chronic pain. So because of the fascial plane block, because of the simplicity, they have increased the delivery of regional anesthesia practice and benefit to the patient. Thank you very much.